We are at our last and final track before the closing remarks and the evaluations. First, we have Judge Glenn. Honorable Judge Ernie Glenn currently works at a drug court magistrate in Bexar County, where he serves as judge and administrative department head of the Family Drug Court, Reentry Court, and Dual Diagnosis Court for district courts. Judge Glenn received his law degree from the University of Houston before beginning his career as a prosecutor for the Bexar County District Attorney's Office. He worked as a criminal defense attorney for over 22 years. Welcome, Judge. And the next panelist is Ms. Cynthia Chapa. She's a licensed professional counselor currently employed with the Center for Healthcare Services. She graduated with a master's degree from Our Lady of Our Lake University and has worked for the Rape Crisis Center for many years as a trauma specialist. Ms. Chapa believes in empowering her clients with their strength and resiliency. Thank you so much, and welcome, presenters.
Okay, I guess I'm going first since my part of the PowerPoint presentation is first too. And I know that there's a lot of talk about mental health, and I think that's more of what we're discussing here today. A lot of the programming is, but let me tell you, you cannot work in a substance use disorder program without dealing with mental health. And we learned that early on in our felony drug court program, and we've had to incorporate more and more mental health treatment into this program as time has gone on. Mm-hmm. And as I was listening to Oscar Kazin and Andy Carruthers a little bit earlier, I was thinking back to when I started out in this field. We didn't do a whole lot for mental health. I was actually, when I started working in the district attorney's office, I was assigned to do the mental health commitments that Sally Unkefer, I think, is doing nowadays. And, we went out there once a week, we did commitments, but we didn't do much more than that. And I typically would see the same people over and over again as we went through the weeks. I mean, we'd put somebody in, they'd get some treatment, they'd no longer be a danger to themselves or others. Judge T. Armour Ball was a judge that heard those cases back in those days, and he would release them, and then 2 weeks later we'd see them back pretty much under the same conditions as before. But we've come a long way since then. And I'm going to go ahead and do the screen sharing and get these slides going. There we go. So we're talking about substance use disorders in the criminal justice system. How do you deal with substance use disorder? There are a lot of ways to do it. You could ignore it for one, but first of all, I thought it might be a good idea to define what substance use disorder is. And normally we don't do a whole lot of reading of our slides. I know that's not the preferred method of doing it, but it's kind of important that you understand what we're talking about, because we normally talk about these things as addiction, and technically though, what it is, persistent use of drugs, including alcohol. Don't forget, alcohol is a drug. We deal with this all the time where people think, well, alcohol is legal, so it must be okay. And say, well, yeah, but if that were the case, we wouldn't have people getting drunk and killing other people on the roads all the time. So despite substantial harm and adverse consequences, there's that persistent use of drugs and alcohol. Substance use disorders are characterized by an array of mental, emotional, physical, and behavioral problems such as chronic guilt, an inability to reduce or stop consuming the substance despite repeated attempts, driving while intoxicated, and physiological withdrawal symptoms. So technically, if you look at the DSM-5, you've got these guidelines which are used to diagnose someone with substance use disorder, and the individual would have significant impairment or distress from the pattern of drug use, and at least two of the following 11 symptoms in order to get a formal diagnosis. When you look at these, it's, from what we see, I think our people pretty much have all of these most of the time, but for sure, they're using more substances than they plan to use. They do it for longer than they planned on. They can't cut down. They develop a tolerance. Every time that they're using the drug, they're trying to reach the same level as before, but that just never happens. You know, as Sade famously saying, it's never as good as the first time. And you hear that a lot, especially from methamphetamine addicts, because they get that super high the very first time they do it, and they're chasing it from then on, and it's never the same. They can never reach that same level, but they're always trying to do it through the destruction of their lives. And you can see that looking through this, that's part of what we're talking about. They've got the cravings, they've got the repeated usage. They can't keep up with their daily lives. They can't keep up with their professional lives. It just becomes something that is untenable for them to go on with their normal lives. And of course, if they try to get off, there are going to be withdrawals, and they're going to have to deal with that. And that can be pretty painful, especially for certain drugs like heroin. So anyway, this gets you to what a substance use disorder is. Now, in the criminal justice system, why bother dealing with it in the first place, right? You know, I'm sure a lot of you folks remember Alfred E. Newman from Mad Magazine. What, me worry? Well, you don't really have to worry about it, I guess. You could just say, you know, an individual is using drugs, he's just hurting himself, right? That's the way we used to think about it, but that's not really true. And I know there are the social consequences, the harm to the family, the harm to your own personal health, of course, but the harm to the family, the harm to society in general, the criminal activity that people get involved in order to chase after the drugs, the thefts, the burglaries, the robberies, et cetera, et cetera. So these things are out there, but a lot of this is boiled down, if you're trying to make some changes, to numbers and dollars and cents. And I've got some numbers. Some of this, I was looking at this. These are numbers that have been put together over the years. A lot of it by some researchers that do work for the National Association of Drug Court Professionals. Some of it's for NIDA. It's from different groups. But I was looking at the first one again and thinking, after 2020, these numbers are not true anymore, because 1 in 10 Americans with a substance use disorder, 1 in 5 with mental health, 20% of those co-occurring disorders. The American Psychiatric Association tells us that depression, anxiety disorders alone are up, I don't know, somewhere between 30 to 40%, maybe more. Some of the figures I've read recently put that at a pretty high level. But in general, during normal times, I think you'll find these numbers would hold pretty true. I've done quite a bit of research looking at different facts and figures from different organizations and some of the meta-analysis of those. And unfortunately, people with these disorders end up incarcerated quite a bit. And you can see the National Institute of Drug Abuse has put out that about 65% of inmates in the U.S. have substance use disorder, and another, say, 20% of them committed crimes when they were high. And only about 11% of these people are getting treatment, so it's not really very many. And it's quite expensive. There's a huge cost to this. I'm looking at these numbers, $200 billion per year. It's probably more than that. It's going to vary from year to year. I would guess that coming into 2021, our expenses are going to be so much higher just because there's been so much more drug and alcohol use in order to deal with anxiety, depression, and other things from the past year under COVID and political upheavals. I mean, all kinds of different things going on. And out of that $200 billion, we're saying 60% is associated with drug-related crimes. Like I was saying earlier, things like burglary, thefts, all kinds of things where there are victims to those crimes, other than the individual himself who's trying to stay ahead of his withdrawal symptoms. So anyway, we look at what can you do about this? Lock people up? Well, TCU has been doing studies for years and years and years among other organizations, but they have a pretty good criminal justice department that's done a lot of studies, and they've come up with an addiction severity index that a lot of us use in our screenings. But one of the things that they look at is that if we lock people up, what's going to happen when they get out? And it's not really quite 100%. I think it's like 98.5% of them are going to be back in jail within a year, most likely. So you're not going to accomplish anything by just locking people up. So, you know, the next question is, what does work? Well, if you have people locked up, you can put them in treatment, and that does work. It really does. It will have an effect. If you give them enough treatment to work with their particular circumstances, when they come out, they will do better. I mean, they can actually hold down a job, you know, be part of their family, and maybe not return to jail or prison. But if they don't get the treatment that they need, then they're going to be recidivating, going right back to where they were before. And in some cases, they'll get out and they'll try to use the same amount of the drug. And this is especially true in heroin cases, the same amount that they were using before, and they're going to overdose. And some of those folks are going to die. So if you've got 85% of the inmate population with substance use disorder or under the influence at the time of their crime, it's really not numerically practical to deal with them in jail. It's going to cost a lot of money, especially, I'm looking at the latest figures that I could find because there's no update beyond what was reported from 2018 to 2019. There was a decrease in prisoners during that year. I suspect that might go up here in the future, but still almost 1.5 million people. How can we afford to treat that many people? There's absolutely no way that we can do it, besides the fact it's not going to be humane to keep everybody locked up for that amount of time that's necessary anyway. So then we come down to what else can we do? And I've listed out 4 different things, you know, having people on probation, people go to counseling, accommodation, and specialty courts such as drug courts. And quite frankly, all of these work. They work at different levels, but all of it does work because you're doing something a little bit differently from what you would do just locking people up and then letting them out. So when you get to probation specialized caseloads, you're going to have officers who are trained to oversee these cases, and they're going to refer out for different types of services, and they're going to keep tight control as they can over what's going on with their individual clients, parolees, probationers. And the downside to this is, although it works to some degree, is, as you can see, community-based intermediate sanction programs, about 50 to 70% of the probationers or parolees fail to comply with their conditions, including the drug testing, the drug treatment, and everything else. So, yeah, I know these figures go back a ways, but I've looked to see if it tends to hold true. And according to the research that Douglas Marlowe has put together, the percentages seem to hold true up to today. And those of you who don't know, Douglas Marlowe is quite a great researcher. He's done a lot of work with the National Association of Drug Court Professionals, and for a while he was the director of law and a few other things, but he is now working with the National Association of Drug Court Professionals, but not an actual director anymore. But he's been doing research for so many years. It's at least 30 years, and come up with some great figures and some great ways of handling things in the criminal justice system. So then we've got counseling. Now this is really the heart of what really works with some of the other things too. Counseling really works, and you're going to get to hear from Cynthia Chapa here a little bit later. She's one of our licensed professional counselors that works with our drug court program, and she can talk to you about some of the different modalities that they use and how some of this works. But it really does work. I mean, look, I've highlighted part of this, that approximately 50% of clients who complete 12 months or more will be abstinent for at least an additional year. Now, does that, maybe to some of you that doesn't sound like a lot, but the people I see every day here are using every day. and most of them are using more than one time a day. I mean, I speak to some of these young guys who are smoking marijuana. I know some people don't think that that's something that we should be even dealing with, but with the strength of the marijuana these days, or the THC, or the cartridges that they can get for their vapes that might be 80% THC, it becomes a big problem. But they're smoking every hour or more, and they're all day long. So it really does become a problem, and it feeds into their depression and a lot of other different issues that they have. So, but anyway, 50% of the clients who complete this will remain abstinent for another year. It's a big deal when you're a daily user. Believe me, it's very tough just to go for a week without using, and then anything longer than that. And it takes a while to get to that point. Now, unfortunately, when you send people to treatment, about 70% of probationers, parolees drop out. They attend irregularly, and further on, you see 90% drop out prior to the 12 months that we need to reach that 50%. So, okay, the counseling does work, but you've got only about 10% of those people who are following through and getting the counseling. And that's we added in there. Marlo found that attrition rates in general for people who are not in criminal justice programs tend to be about the same. People just don't finish their counseling. If they did, the numbers would look a lot better. So what we can do in a combined approach. You've got the probation officer, you've got specially trained case managers, you've got treatment providers. They're working together, and you're going to get a much higher level of success rate with this type of approach, because you got more eyes on the folks and they're being held more accountable. And this does work too. You can see the percentages are going up. Things are looking better and better as we start working together. So it seems that some people figured this out after trying these other approaches, that let's add a little bit more to this. So specialty courts were started, and specifically the drug court started in 1989 in Dade County, Florida, which is Miami. And what they decided to do, rather than continue this revolving door of people going in and out of the system because we're not dealing with their drug issues, what they decided to do is, let's get together and work as a team. Let's have the law enforcement, let's have the probation, let's have the defense, let's have the prosecution and the judge, and let's all work together. Let's do staffings and let's do court reviews with these folks, and let's do it on a regular basis. And now that we've been doing this since 1989, we have a pretty good idea of what works. And that's why there are more than 3,000 treatment courts in the United States. And that's why we can serve 150,000 people annually. And since 1989, up to the date that the National Drug Court Institute put these numbers out, 1.5 million people have been helped, and billions of dollars are saved, because as it turns out, it's cheaper to treat people and deal with their substance use disorders than it is to lock them up. And it's not just that there's less money spent doing that, it's just that there are more savings elsewhere too. Just think, how much does it cost to take care of a child with fetal alcohol syndrome? Lots, millions of dollars to work with all the different children who have things like that, or different problems that are caused by people who are using drugs and during pregnancy. So just say the money that's saved from that, it turns out to be millions or billions of dollars. So it's really a big savings in various ways. It's a savings to humanity in general, and you've got people who are responsible, who are working and holding jobs. They're taking care of their families. They're raising their own kids. It's not costing all that extra money. They're paying taxes. I mean, there are a lot of benefits that come from taking care of people's drug use and mental health disorders. So anyway, this drug, at this point, it's pretty settled that drug courts and specialty courts in general are very successful. And you can see treatment courts refer more people to treatment than other interventions, and the completion rate is nearly 60%. That's actually very good, because what did we learn a little bit earlier? That 10% of the people will complete counseling. This is 60%. You got a six times the completion rate that you had just with the counseling alone. So we're making some serious progress here when we take this type of approach. And as we have found, there are researchers out there besides Marlowe. There's Ed Latessa, who's done a lot of great work in this field, that most effective programs are based on certain principles: the risk, need, responsivity, and then there's program integrity, that the programs are properly run by people who follow best practices and have the training in order to do that. So there's a lot of science to this, and I can tell you the things that I'm just kind of going through here today, like the risk need principles. You need a whole lot more time to really understand, to learn all about this and how it works. And just talking about risk needs and how that works in your criminal justice system, I've gone to trainings that last 2 or 3 days for that. I've gone to trainings that last for a week for some of the things that we're touching on today. And I've gone to trainings that deal with trauma in the criminal justice system and mental health issues that last, I mean, a week's not enough time for some of these things. You need more and more education in order to learn more and more about it. But these risk need factors that I've listed come from Ed Latessa's work, and these are the top 8. There are more, but these are the top 8 things that they look at: antisocial, pro-criminal attitudes, pro-criminal associates. I mean, let's face it. I was in private practice for quite a few years and a prosecutor, and when I was in private practice, my clients hung out with people just like them, people who were doing the same things that they did. If they were dealing drugs, they were hanging out with drug dealers and people who were using drugs, of course, because they need clients to sell them to. And guns, breaking into places and things, you know, people do those things together normally. You've got next on the list, antisocial personality pattern conducive to criminal activity. We're still in the same range here. History of antisocial behavior. The family factors aren't so great either. We talked about dysfunctional families. Well, these are seriously dysfunctional families, and they're always low levels, or almost always low levels of personal, educational, vocational, financial achievement, low levels of involvement in pro-social leisure activities. You know, you don't see a lot of people out there dealing drugs and getting high who are riding bicycles and going hiking up in the hills. They're out there doing the other stuff and not the things that some of us might do. And of course, there's the abuse of alcohol and drugs. That's another thing that plays into this. And I'm bringing these up because these are the factors that we try to focus on in order to get people to change the way they do things. They've got to change the way they live their lives and get away from the way they've been thinking, the things they've been doing, in order to really get away from the drugs and alcohol. Otherwise, it's just not going to happen. Yeah, you can lock somebody up and they'll stop using drugs, but as we've seen from the TCU studies, they're going to use again when they get out. But if you can start taking care of some of these risk need factors, you're going to find that you can make some changes. And a lot of research went into this, but most intensive interventions you should put into the higher risk people, not the lower risk. I mean, people like you and me, you know, we go in front of a judge and get put on probation. We're going to pay our fines, do our community service, and get this over with. You know, not the people that we're talking about. They're going to need the high risk and high needs people we work with. They're going to need at least 200 hours of counseling. That's what we're talking about, dosage of treatment, at least 200 hours to be effective in getting them out of the criminal justice system. And at this time, it's a good segue, since I'm talking about treatment, to get Cynthia Chapa on board, and she can start talking about the treatment modalities for substance use disorder, co-occurring, and trauma. So Cynthia, I'm going to turn it over to you.
Thank you, Judge. So I'm Cynthia Chapa. I do work with felony drug court. I also will work with mental health court And now we just acquired domestic violence court. So hello, judges that don't know me yet. So I'm going to talk to you about the types of treatment modalities for substance use disorder and co-occurring and trauma. And can I have the next slide, please? So Judge Glenn already talked about some of this, and I just thought I'd put there's the criteria for substance abuse disorder. Of course, it's the cravings that they have for the substance, the wanting to cut down and not being able to, taking larger amounts of the substance, neglecting other parts of their life for it, continuing to use even when it causes problems in their relationships, and using substance even when it puts them in danger of using it. Next slide, please. So what are co-occurring disorders? And I believe in empowering my clients too, or our clients, but my clients with education and educating them on what's going on with the program, what they're getting into. I like to go over with them about co-occurring disorders, and this is part of what we talk about in our groups also. So co-occurring refers to the condition in which a person has existing mental illness and substance use disorder. And people with co-occurring disorders, they're at risk for relapses, hospitalizations, financial problems, social isolations, family problems, homelessness, sexual and physical victimization, incarceration, and serious medical illnesses. Many of our clients that we've had, they come into our program, have lost everything because of their substance use disorders, and also sometimes because of their mental illnesses. Here again, I find that it's empowering to educate them on what's happening with them. Next slide, please. So a little bit of statistics, 8.9 million Americans are living with a co-occurring disorder, and 7.5% only of the enroll in a treatment program. Many of the clients don't think that they have issues because they're so used to being in their addiction, and they're so used to being in their mental illness. To them, it's normal. And once they get into counseling, and once they start realizing what's going on with them and what's happening with them as far as their mental illness is concerned, they start thinking to themselves, well, you know, I want to be normal. And you teach them that, you know, to be their normal, but they talk about this. Next slide, please. So some of the common mental illnesses that we deal with are anxiety disorders. There's generalized anxiety disorders, panic disorders, post-traumatic stress disorders, obsessive compulsive disorders, mood disorders. There's personality disorders. There's borderline personality, narcissistic personality, histrionic personality, and antisocial personality. Then we have people with eating disorders. Anorexia nervosa, bulimia, binge eating. Then we have learning disorders, which many of our clients have too, which ADHD, dyslexia, and autism spectrum disorders. Many of these disorders too, it's very possible that because of the trauma that these people have experienced in their lives, they're going to have symptoms of these mental illnesses. It doesn't mean that they have a personality disorder or a mood disorder. A lot of times, many of these symptoms comes from trauma. They're trauma-based. Next slide, please. I want to talk about the LGBTQ versus the general population also, because members of the LGBTQ community are more than twice as likely, 39% versus 17%, to abuse drugs and alcohol than those who identify as heterosexual. So when looking at LGBTQ adolescents, that number climbs to 90%. And they're likely to abuse drugs too. Next slide, please. And the LGBTQ2 community face different challenges than those who do not. There's workplace discrimination, there's violence, there's internalized homophobia, there's judgment, disapproval from family members, judgment within the LGBT community. And I have these slides here too, because some of the clients that come into to my office anyway, have this as an issue as well, in addition to the mental illness and the SUD that they're experiencing. Next slide, please. So what is trauma? And I know that Dr. Speedland did a really wonderful, talk about that. And she came to talk to us too at the Rape Crisis Center. I remember her when I was there. But what is trauma? So according to the International Society for the Study of Trauma and Dissociation, trauma literally means wound, injury, or shock. So approximately 10 to 25% of adults who are exposed to extreme stressors may develop acute stress disorder or PTSD. And if you think about it, many of our clients that are suffering from mental illnesses and they come to do our intakes, many of them have been exposed to life or death situations, child abuse, domestic violence, rape. Many of our clients that have come here too have talked about some of the deaths that they've seen when they're out in the streets. They've talked about people that they've seen passed away. So many of our clients have experienced traumas, and it's very possible that they have PTSD. So according to the International Studies for Traumatic Stress, trauma is events involving actual or threatened death or sexual violence in different ways. Next slide, please. It's not showing. It's the types of treatment. That one. Thank you. So the types of treatment that we have also that are helpful for clients with substance use disorder, there's residential treatment. And this is like an extended stay, would provide space to recover with zero distractions. And this are good places to have people like to stabilize and to get away from maybe people who are enabling them. And a lot of these residential treatment areas too have counseling in there and group therapy. There's outpatient treatment, which is what we do, meet with recovery specialists 2 to 3 times per day. And then there's day treatment, partial hospitalization, which are helpful also. And these people meet with teams of specialists 8 to 10 hours per day. Sober living community, which provides environment of continued support. A lot of times what people with substance use disorder need is routine also, which is what try to educate them on. They need routine. Try to think, what do you do in your day? How does your day go? Which is why we also provide counseling once a week and groups twice a week. In inpatient, they have groups every day. And here again is to give them routine and discipline. Next slide, please. That's the one. So now I'm going to talk about different types of counseling and helping people. When I first started here, I realized that I was going to be working with mandated clients, and I thought, oh no, this is going to be hard to do. But actually, a lot of the clients that come here are willing to talk and willing to change. And the way I try to explain it to them is like, you have an advantage here. You have counselors that want to help you. You have case managers that want to help you. You have a team of people that are supporting you, and they want to help you to change too. And yes, I tell them it's not going to be easy, because what I tell my clients, part of counseling is you're going to feel worse before you feel better. But once you keep going, it gets better and it gets easier. So I'm going to talk to you about motivational interviewing. These are types of therapies that are helpful for people who have substance use disorder. Excuse me. So Motivational Intervene was created by William Miller, and its purpose is to strengthen the client's own motivation and commitment to change. It meets the client where the client is. And I like to tell my clients that too, meet yourself where you're at this moment in time, which helps by day-to-day living also, and helps them to move toward their goals by drawing out and building their readiness to change. This is also strength-based. It's looking at the clients as experts. As Dr. Spielenson, the client is the expert. And I know sometimes it doesn't seem like it, like somebody said before, because of the route they chose to take for themselves in their life. But the client is the expert, and the client pretty much knows what they need to do for themselves, especially when they get into these programs. And it's helping them to see that, either to reframe things for themselves, to make it seem like they're the ones that are not seeing, but that they're the ones that want to change. How do you want to change your life? Where do you want to go with this process? Next slide, please. DBT? Thank you. So dialectical behavioral therapy teaches clients to regulate their destructive behaviors that come from extreme, intense emotions. So many of our clients, when they come here too, if they do have, let's just say, issues with anxiety or depression, many times if they come from places where there's like childhood abuse, they weren't allowed to regulate their emotions. So some of them are really gonna have to learn how to react. I'm trying to think of too many words in my head right now. Not to react, but to respond. And many of our clients are very reactive. If you tell them no, they're going to come at you as to why they think that they need to do something. So what we try to do to teach them is to respond. So take a step back and just respond. So it's effective for substance conditions, eating disorders, anger issues, self-injury, and especially borderline personality disorder. So many clients too that have been sexually assaulted as one of their traumas exhibit symptoms of BPD. Doesn't necessarily mean that they're they should be diagnosed with it. 4 key skill sets are distress tolerance, emotion regulation, mindfulness, and interpersonal effectiveness. Next slide, please. So EMDR, eye movement desensitization and reprocessing. This is very helpful for people who've been traumatized, who have like disturbing memories come up of their trauma. It was created by Francine Shapiro. It focuses on changing the emotions and the thoughts or behaviors resulting from the distressing event. It allows the brain to resolve unprocessed traumatic memories. It uses bilateral stimulation through eye movements, taps. Sometimes there are light bars or TheraTappers. And I was actually using the TheraTappers before this to tell myself that I am calm, and it works really well. So when people want to know what bilateral stimulation is, so EMDR works by activating both hemispheres of the brain at the same time through bilateral stimulation. So typically people are right or left side dominant, but with EMDR, both hemispheres are working at the same capacity and speed. This allows for rapid processing of the brain. This connection allows trauma to be identified in the brain by highlighting the affected trauma network. It then rapidly clears out the trauma, moving it from being stuck in emotional mind, which is typically the right side, and processing to the logical mind. So the individual is processing the trauma from both hemispheres. And what it does is it allows the person to come to some form of acceptance of what happened to them. And whenever they think of the distressing event, they're able to talk about it without the emotions coming up. So it also regulates the emotions as well. It's very helpful for people who've been traumatized if they're open to it. Next slide, please. So we also have Seeking Safety, which we used to like to use in our groups. It was developed by Lisa M. Navajidis. It's evidence-based counseling model to help clients attain safety from trauma and or substance abuse. It addresses trauma and addictions without clients having to delve into their traumatic narrative because we don't want to re-traumatize them, and we also don't want them to relapse. It can be conducted in groups or individual therapy, and somewhere in there too, I had individual and group therapy. I may have missed that, but that's okay. So individual therapy also is very helpful for our clients too, because it helps them to go into a one-on-one situation with a client. You get to build rapport with them, and they get to talk about their personal issues too. In group therapy also, it builds community. It's also very helpful for clients to be in there. It's unfortunate now because of COVID, we have to do our groups over the phone or on Zoom, but it's very helpful for people, and especially when they start talking about things that happen to them, someone else will come in and talk about how it's what helped them through their process of recovery. Some of the things that we cover in groups here is recidivism, wellness, overall wellness, relapse prevention, which we did last night. We like to educate our clients about co-occurring disorders and how this affects them, because here again, I think education is very helpful for our clients to know what's happening with them. We like to talk about the neurobiology of addiction too, what's actually happening in the brain. I like to talk about trauma and how that affects people too, and what's happening in their bodies, which has been really eye-opening for our clients. And next slide, please. So best practices, according to SAMHSA, there are 4 dimensions that support recovery. There's health, overcoming or managing diseases or symptoms and making healthy choices, both physical and mental. There's home, having a very stable and safe place to live. And you think about it, people who've been traumatized too. Sorry, I'm big on trauma, but I am. It's like bringing people to a safe place and helping them to feel safe within themselves as well, and empowering them to know that they can do this. They can recover from their substance use. Then there's purpose. Many of the clients say that, I don't have a purpose. I need a purpose, because it's difficult for them to find the job. So having meaningful daily activities and having the independence, the income resources to participate in society. Then there's community. People want to get back into community. They want to be able to go and have their own apartment, have their own job, probably reunite with family if they can. So it's having relationships and social networks to provide friendships, support, love, and hope. And it's about taking an integrative approach to the recovery, a holistic approach, looking at their mental, which is what we do, their spiritual too, because one of our groups is about healthy spiritualism, and also their physical. And if there's any questions, I think we're ready for them. I finished early.
Thank you. Okay, yes, we do have some questions. I have too many windows open though to find them. Okay, first one is, let's see if Judge Glenn, maybe you have this one, or maybe Cynthia. What are the actual costs people in these programs have to come up with to pay for their drug tests, treatment, etc.? I found out this week that people who go into the methadone clinic downtown have to pay $13 per dose, and the doses are normally daily. I was shocked. That was a lot of money to our poor clients. Can one of you speak to that?
That is true. Well, Cynthia, did you want to bring something up? It's true that there are costs to some of these places, places that where folks go, like River City, other locations for methadone treatment. Yeah, there are some programs out there that can pay for some of these things too. And if we get a lot of our clients hooked up with those different services. Too many probably to mention, plus I probably wouldn't get them all right anyway. But we do have quite a few different programs out there to pay for some of these things. Yeah, there are costs that are involved, but when we have the resources, we pay for as much as we can. And I think Cynthia can probably talk a little bit more about some of these things.
Yes, we have a program here that if a client is eligible for it, we have a methadone clinic. And all they have to do is call Center for Healthcare Services to see if they're eligible. But we do have, and it's grant funded, so they may not have to pay.
And yes, there are other costs too. And we do have grants that pay for a lot of the treatment. And sometimes we have grant money to pay for urinalysis. And we use that as far as we can. But because there are limited resources, at some point, folks in the program will have to start paying for some of their services. And typically, we save that for later on in the program when they actually are full-time employed and have the resources where they can afford to pay for some of these things.
Judge. Anyone else? Any questions for Judge Glenn or Cynthia on substance use disorders and the interface with the criminal justice system? You got a big shout out from Judge Kazin for developing a specialized trained court for in the felony side and the district court side dedicated to drug court, and Judge is just making a recommendation that we do the same on the county side. So maybe we can make that happen, Judge. And a shout out also to Judge Speedland Gonzalez for the work that she's doing with family violence court. Specialty courts change lives, right? Now that, what does the big banner say, Judge Glenn? Drug court works.
Drug court works.
Drug court works. Short and
Drug court
sweet.
does work. Specialty court work. We define them as specialty courts now. In fact, we've changed the name of the Texas Association to the Texas Association of Specialty Courts, not drug courts now, because there's so many different types of specialty programs. And I want to shout out to Judge Peter Sakai, by the way, who is now the president of the Texas Association of Specialty Courts. And that's only been for a couple of weeks now, but he's already proving to be a great leader.
All right, y'all, if that is it, I don't want to stand between you and your weekend.